it as well. Over the past 3 decades, advances in cancer treatment have resulted in improved survival rates and more people living cancer-free for many years. Although these treatments do save lives, they can sometimes cause serious side effects, including heart problems. In the medical world, we call this cardiotoxicity. North Kansas City Hospital is home to 14 specially trained, board-certified emeritus health cardiologists who diagnose and treat a range of heart conditions, including those related to cancer treatment. I'm excited today to introduce you to Dr. Malay, one of our cardiologists, who's here today to talk about which types of cancer treatments may cause heart-related side effects. She will also talk about some signs and symptoms of a possible problem and some treatment options. Dr. Malay received her medical degree from Osmania Medical College in India. She completed her residency at Yale, New Haven Hospital, St. Raphael campus, that's a mouthful, at the University of Connecticut Health Center. She also completed her fellowship at the University of Connecticut Health Center. Joining us after Dr. Malay speaks is Stephanie Moore. She's one of our physical therapists and a member of our cancer rehabilitation team. Stephanie will talk about a new program that can help improve heart health after cancer treatment. Please join me to welcome Dr. Malay.
I lived in Connecticut for 7 years, but still not a Patriots fan. I'm with you all. Thank you for coming in on this day. And yes, my family was there in Miami cheering for Super Bowl to come home, and they brought it home. One more reason we should be wearing red this week. Anybody else know? Other than Chiefs. It is Heart Month, yes. Actually, first Friday of every February is the Wear Red Day. So please don't forget to wear red again on Friday. I know it's not the Red Friday the way we do it, but Chiefs gear is fine, just wear red. All right, today's topic is not the most fun topic. Like the last time I spoke here, I talked about women and heart disease. It's always fun to bash men and have jokes about it. There's nothing really that funny about cancer and heart disease. So I'm going to try to make it as simple as possible, okay? All right. So what's the connection? Let's see, from the audience. How many of you have ever been diagnosed with cancer? Is there a number? How many of you have been diagnosed with heart disease of any kind? Strokes, heart attacks, aneurysms? Fair number. So you know heart disease is the #1 killer in the United States. But right next to it is cancer. So today we're going to learn how these two things actually are connected, make each other worse, honestly. So we have to be worried about two things that are trying to kill us, right? The great thing about cancer therapy is over the last 20 years or so, there's been a lot of improvement in the number of people who are getting treated for cancer and actually are living longer. A lot more people, a lot more survivors now than ever in the past. Okay? About 15.5 million survivors were there in 2016. That was just 3-4 years ago. And the projected number is about 26 million in about next 20 years to come. That's a lot of survivors, a lot of cancer survivors. And right now, like 2019, back from 15.5 million to 16.9 million just in 3 years. That's an exponential growth in the number of survivors. So how quickly are these cases of cancer coming up? Which is the most common cancer? For men, it's prostate cancer, and women, it's breast cancer. Does anybody know which one's the most common killer among the cancers? No, actually no. For both men and women, lung cancer is the #1 killer. Okay? The good news is though, for the first time in the last 2 decades, we have documented decrease in the number of deaths and cases of lung cancer. Thanks to all of you who have quit smoking or ever thought about quit smoking. Thank you. All right, so let's get to the, yeah? Oh, you can't hear me? Okay, all right. I've been told I'm pretty loud, so I'm trying to be nice. Okay. And I do have like kind of a little bit huskiness, probably from all the screaming from Sunday. Good. Is that better? No? No? Can you increase the volume, please? Okay. Is that better? Okay, thank you. Thank you for stopping me before we got to the real facts and the real matters. So the cancer and the heart disease is not just about the cardiotoxicity of the cancer therapy. The relationship starts even before the diagnosis of cancer happens. So let's look at what is it that connects them before, what is that connects them during, and what is that connects them after, and sometimes many years after the treatment. So this is kind of, the medical way of showing things, but let me walk you through this. You probably have heard about how smoking increases cancer. You probably have heard about how smoking increases heart disease and stroke. Are these related? Smoking increases both. So if you are someone who has smoked and has a history of excess alcohol intake, or have been physically inactive, meaning you tend to lead a sedentary life, be it your job or be it your disability from something else, all of these actually place you at a higher risk for both heart disease and cancer. So these are what we call modifiable risk factors, because we can actually do something about it, and bidirectional risk factors, because they're both increasing risk of cancer and heart disease at the same time. All right. So unfortunately, even though we are making a lot more people live, and even after the diagnosis of cancer, the cancer diagnosis associated with obesity or excess body weight are actually on the rise. The one cancer I keep seeing that is popping up more and more is actually hepatocellular cancer, the liver cancer. And it's usually diagnosed late too, so people don't do very well in these cancers. So what are these cancers that are associated with obesity? Esophageal cancer, liver cancer, postmenopausal breast cancer, the breast cancer that happens later on in the life. Why is that the case? The most common theory behind that is obese people have more fat tissue that converts certain hormones to bad hormones that create breast cancer to happen. So that's the theory behind it. Ovarian cancer and endometrial cancer have also been associated with obesity for the similar reasons of hormone translation in fat tissue. All right. Again, this is the reason I put up this slide is there are many reasons we should be proud of United States, but not this one. The top 10 countries with the highest percentage of overweight and obese adults, we're second to Mexico. We are almost there. We're almost at number one. We shouldn't be. We should be able to address that. All right, about 1.9 billion adults worldwide are either overweight or obese. Okay, so why does leading a sedentary life have anything to do with cancer? Do I have a straightforward answer to that? Probably not. The way we gather information in medical field is we look at cases. We look at what's common to them. We look at if we do something to that, does it change anything? And then we come up with our ideas, okay? Over the years, they looked at lung cancer patients and colorectal cancer patients. And they saw if you're very active, you're medium active, or not active at all, what are your chances of having these two different kinds of cancers? And there's a pretty good correlation that people with low cardiorespiratory fitness, as in, can you walk 2 or 3 blocks without stopping? Can you take a couple of flights of stairs without stopping? That is the cardiorespiratory fitness, okay? If you can't do that, you probably have a higher risk of having colon cancer or lung cancer. The reason most of these people think about it, who are the people who cannot walk 1 or 2 blocks are the ones who probably have smoked, have COPD, are short of breath for other reasons. So it's not like there's a brilliant science behind it, it's because the common things are commoner. There's a reason why people aren't able to do it. All right. This is the most recent publication on breast cancer. They took 4,000 women who had breast cancer, and a simple question was asked, how is your activity level? How much workouts, or like, how active are you? How many hours a week do you work out or are active. And they followed them for 15 years, and people who are able to do more in terms of physical activity are the ones who are still surviving at the end of those 15 years. So yes, exercise has a lot to do with it. Your cardiorespiratory fitness has a lot to do with it. That's why at the end of my talk, we have a physical therapist from our hospital come and talk to us today. So we have more to learn. All right, if you have cancer and you've been asked to participate in a research trial or something, there's something called the ECOG score where they say how much activity are you able to do, and they give you a score from 0 to 5, and only in cancer you get a score for being dead. I have no idea why they have dead. I'm like, what person would want to be a part of that research project? That's the only joke I have. Okay, so what do cardio-oncologists do? As a cardio-oncologist, I have to have some basic knowledge of the common cancers that have common risk factors for cancer. I should be able to try and prevent the bad effects of some of these cancer therapies. Not every cancer therapy causes cardiac side effects. There are some that are have common side effects, some that have rare side effects, and some in between. I have to be able to pick and choose and say which patients is too high risk to go through a lung surgery or radiation if they have a heart problem. So that is my role as a cardio-oncologist, is to make your body in its best position to take on the cancer. All right? Does every patient with cancer need to see a cardiologist? No, because I would never go home otherwise. All right. So that was before chemotherapy, and patients come to me. If they're elderly, if they've had multiple risk factors, or they've already had a heart attack, I make sure their medications are all in place. I make sure their blood pressure is good. I make sure that they can actually start doing a light exercise program so their body can prep for the upcoming storm of the chemotherapy. This is an interesting fact. They took all patients who were given the diagnosis of cancer and followed them for 6 months. That's a short period of time. Within that 6 months, about 5% of the patients who had cancer had a heart attack or stroke, as opposed to 2% of patients who never heard the word cancer. So the word cancer itself, even though it's as much anxiety-provoking and stress-inducing, has more to it than we know. All right, so where does the cardiac complications from chemotherapy come from? It's not just the heart muscle. It's not just cardiomyopathy, which is what the term you commonly hear in conjunction with chemotherapy. It actually has side effects deep to the vessels and all the way to the capillaries. Sometimes it's just swelling in the legs. Sometimes it's the severe high blood pressure that is really difficult to control, and we would have to say, hey, you have to change your chemotherapy. This is not going well. All right, different cancer drugs have different side effects. The most common one we're going to talk about is the anthracyclines. The most common and the feared one, I should say, which has been documented over the past few decades, was with the anthracyclines. That's how people first started to find out about chemotherapy and cardiac disease, was when they saw patients come back with weak heart muscle. But now, you probably have heard this commercial from KU where they say, it's like a thumbprint and a fingerprint. Everybody has their own little fingerprint and we're doing this immunotherapy. Great. The only reason people are surviving is because of these new cancer drugs that are coming. But the more new drugs are coming up, the more we are learning of their side effects. And we are learning that some of them interact with cardiac medications, some of them cause arrhythmias, some of them mess with their blood pressure, and the worst swelling in the legs I've seen with a couple of medications and chemotherapy that won't go away unless you change their therapy. So that is where my cardio-oncology role comes in play, is to tell the oncologist this is an ideal medication for them, or no, this is not an ideal medication for them. So as I said, some cardiac effects demand discontinuation of the cancer therapy, and we do that very carefully. Sometimes, if that is the only choice and it's going to affect the longevity and the chances of you living or not, well, then we try to treat the heart disease as much as possible continue that medication at the shortest and the lowest possible time, and then we say, we just want you to win over that cancer as much as we want you to be safe from your heart. Oh, let's talk about the common cardiac side effects and the cardiac medications. How many of you have heard the red devil? People with breast cancer, colon cancer have heard of the red devil because the medication is red and it's usually hung in a red bag. It's called the doxorubicin and it's age-old medication. Works great because it actually goes and kills the cancer cells. Physically kills the cancer cells. But years after we started using anthracyclines, we realized that there's a small protein interaction. One of the proteins it kills in the cancer cells also exists in the cardiac muscle. Fortunately, it doesn't happen to everyone. About 10% of the people up to 10% can have this effect, where their heart muscle goes really weak on them and they have congestive heart failure and cardiomyopathy. Unfortunately, even though there are some lucky people who have all the function back, most of the time this is irreversible damage. And sometimes it's not found out until late. And how can I prevent that? Is basically doing a few things. One, making sure you're on cardioprotective medications before you start anthracyclines. Especially if your blood pressure is say 140, I have a lot of people come and say, that's too high for me, it's not that high. But if you have a blood pressure 140, let me start you on something that might be able to protect your heart muscle from the side effects. I know you're probably going to lose weight. I know you probably are going to eat less and your blood pressure is probably going to be lower. But if I can do anything to prevent this from happening to your heart, please let me do that. Alright. Sometimes it can happen immediately, sometimes late, and sometimes it's almost a decade. I've seen patients even after 10 years. Alright, so as you can see, if this is the congestive heart failure line, the good thing about anthracyclines is we do know that the more dose you get, the higher the risk of this cardiomyopathy. So if somebody's heart muscle is not great to begin with, we always caution them. Do not give them high dose. Do not add it with anything that might increase their risk, or do not add radiation to it. These three things together, it's like a recipe, perfect storm for cardiomyopathy. So previously they used to do a lot of high dose doxorubicin. They do not do that anymore. Actually, oncologists have come a long way in the treatment world to fix this. Some of the reasons why people would have a higher risk of having cardiomyopathies, age more than 60 or 65. Females actually, unfortunately, are at a higher risk. If you start off with a low normal or kind of an abnormal echo to begin with, your chances are higher. If you have large doses, we talked about that. Sometimes it's an infusion versus bolus. I mean, they give you all at one time versus a slow infusion. And there are some formulations that now I think most of the pharmaceutical companies know about this formulation theory, that if you add it with certain liposomes, it has less cardiac side effects. So they've actually worked with this. This is more of, previously they didn't know, but now they know. And how many of you have heard about Herceptin? Breast cancer patients. Herceptin and the doxorubicin or the red devil together have a higher incidence of cardiomyopathy. So if you don't have to use it, don't use it, but I know a lot of patients actually need it. Herceptin has been a great drug for breast cancer. And if you have multiple cardiovascular risk factors, if you've smoked, have had a heart attack already, if you have high blood pressure, high cholesterol, please have these addressed even during, before, or after, whatever it is. Don't ignore them. Alright, so I don't want to bore you with the details of it. I just want you to know that the heart failure that is associated with cancer therapy has a much higher risk of mortality. People are usually sicker because they've just been through cancer therapy. They're weaker, their physical capacity is lower, they've been through all these like toxic therapies, and can't blame them, because if it is affecting your heart muscle, it is affecting your skeletal muscle. People don't have the same energy after chemotherapy for a reason, right? So these people do poorly, those with the chemotherapy associated with cancer treatments. Alright, so this is just telling me that those who have added therapies, like anthracycline, Herceptin, and radiation together do the worst, and one at a time is better. Okay, Herceptin. This is the second line of, it's not really a chemotherapy, it's more like an immunotherapy. and they give it to breast cancer patients who are called HER2 positive. Okay, it's like a growth factor. It's a terminology they use to tell you what kind of cancer you have. Why is it important? Because it decreases the recurrence. Like your chance of having recurrent breast cancer is lowered by half. And this otherwise doesn't have a lot of side effects. It's once every 3 weeks, you get an infusion, you go home. Most patients really tolerate it really well. And it decreases the mortality of chances of dying from breast cancer to about 33% less, 1/3. So it's a great drug. So that's why they give it. They give it to patients about 12 to 15 months, over a period of 12 to 15 months. And when you're on this particular drug, you're supposed to get an echocardiogram every 3 months. That's the gel test. They put gel on your chest and take pictures of your heart. What are we looking for? Any bad effects from Herceptin. What does Herceptin cause? Congestive heart failure, lowering of your heart pumping function. The specific measurements we look for, and depending on those measurements, we make recommendations as to whether you can continue it, decrease the dose, increase the frequency, whatever it is. But it really needs to have this, and it's an FDA recommendation. So if you're on Herceptin, you're supposed to get that echo every 3 months until you finish the therapy. All right, I was just going to show you an echocardiogram. It is easily available. It does not have any radiation to it. The discomfort is only when they're pushing on you just to get the best pictures they can. We measure how big your ventricle is getting, your main pumping chamber of the heart. We give it a number called ejection fraction and this new measurement called a strain rate. Strain is where we see how much the muscles are lengthening and shortening, just like a rubber band, okay? We give it a number and we look for a particular number. Every lab, every machine is different for this. In our lab, anything better than -18 is good. -18 and above, not -18 and below. Unfortunately, they put that minus because it's shortening and lengthening. It has nothing to do with numbers. So numerically, 18, 19, 20 are better, not 18, 17, 16. If you're going lower the other way, then you need to be more careful. And actually, we started doing this about a year and a half ago, and we've taught all our techs how to do it. They know what we're looking for the moment the diagnosis is cancer or chemotherapy or cardiomyopathy, or if an oncologist orders it, they automatically do this so you don't have to go back and get it done. Okay. We also do 3D images of your heart when you were getting an oncology related echo, and this is really reproducible and it's less artifactual, but sometimes patients who've had radiation to their breast tissue or have had lung surgeries, it is hard to get echo images on. It's just not your fault, it's not the tech's fault, it is just hard. I've actually recently seen a patient who just came after radiation and I'm like, I'm sorry, but I don't even think we can do an echo on you because the skin was so raw from all the radiation she's received, and we had to postpone the echo by a month for her to heal from that radiation burn. All right, other side effects. Even though cardiomyopathy is the most dreaded one, I've actually seen a patient come in with chest pain and actually had an EKG that looked like heart attack. She was wheeled right to the cath lab, but she wasn't found to have any blockages. Can that happen? Yes. 5-FU is one of the medications, one of the chemotherapy drugs that we give that can give what we call spasm of the coronary arteries and makes it look like they're having a heart attack. And the right thing to do is discontinue that medication and only challenge if the patient has not had any heart damage to make if they have chest pain again while giving the medication, that is not the medication. That's what happened to that patient. She was re-challenged in a different way, and with medications and everything, she had chest pain and they had to discontinue that chemotherapy. Some of the newer immunotherapy medications that are like Keytruda, ibrutinib, all of these multiple commercials that are coming up on TV, a lot of them have high blood pressure and atrial fibrillation as side effect, as one of their side effects, and they can also affect what we call the QT interval on EKG. So some of them now demand that you get an EKG before you get the medication to see if it's going to be acceptable for you, because some of them can give you ventricular arrhythmias.
Is that a side effect? Is that cumulative after having used that over a long period of time?
So there was a recent publication on ibrutinib, and they said the risk of having AFib is pretty significant. But once you're on the medication, it kind of takes some time for it to wash out. I don't think they have long enough data to say whether the AFib is ever gonna go away or is it just gonna stick with you, the risk of it. What I know is, ibrutinib, every time you challenge with ibrutinib, you have a risk of having AFib. And there are alternatives that do not have AFib as a side effect, so sometimes they have to choose that. The tricky part is when patients have cancer, they're also anemic, and the treatment for AFib includes blood thinners. So it becomes a conundrum as to where we have to pick and choose the right treatment. And I don't think it's cumulative, because I think the way it's dosed is that they wait for the next dose to come on when you're ready for it. I may not be right about that, I can look into it more, but I have seen AFib just related to ibrutinib, and the only way we could have treated that patient was to take him off because he kept having more AFib. Okay? You're welcome. Alright, so treatment-wise, we really don't have a magic drug to reverse the effects of cancer therapy. What we do is we use certain classes of medications that are recommended by American College of Cardiology and American Heart Association for anybody with congestive heart failure. What we have known for the last few decades watching all the patients with congestive heart failure is that these two classes of medications prevent progression and worsening of the heart pumping function being low, and actually help with the hemodynamics so you can function better at the level of pumping. And ACE inhibitors like lisinopril and ARBs like losartan, Diovan, there are a few of these, and you probably have heard metoprolol, carvedilol. These are the very commonly used medications in the cardiology world, but right now we don't have anything better than that. I'm sure with the growing number of survivors and the growing number of cancer opportunities and medications, we will keep working on it to find the right drug, hopefully with less side effects, because imagine giving someone a beta blocker when they've just come off chemotherapy and say, hey, here's your medication. By the way, the number one side effect is fatigue. And you know, it's unfortunately, I wish I could come up with something that is going to treat you better than that, but right now we don't have anything specific for this condition, but we're working on it. All right. Again, how do you prevent worsening? Take care of your diabetes. Take care of your high blood pressure. Even walking a little bit and giving up that smoking would help. So when we talked about anthracyclines, there was previously, in the old age when they were using 350 milligrams per kilogram dose, like the really large doses, they actually came up with a medication called dexazoxone. It's an iron chelating agent. It just goes to the problem where it's causing and stops that step where it's killing the cardiac myocytes, which is great. It should have worked great. But there were some concerns in pediatric population about recurrent malignancies. Like they did well, they didn't get the chemotherapy, they didn't get the cardiomyopathy from chemotherapy, and years later they had another big malignancy. And they thought this may have been related. So they are still working on it. But I think in the next 5 to 10 years, they are going to come up with more usage of this. All they have to do is prove that either one, it is safe, or two, find an alternative if it's not safe. And let's see, radiation. How many of you, anybody have radiation? So radiation, if it is to the left side of your chest, has greater implications for heart side effects, okay? Because previously when people had lymphoma, they used to get what they call the mantle radiation, where they just literally like burn the entire mediastinum to kill all those lymph nodes and everything. And those are the patients we still see rarely, but it's now very rare we find those patients who have valves calcified, arteries calcified, and it is so hard to treat them because everything is stiff and tight and you touch them and it crumbles, kind of anatomy that surgeons didn't want to touch those aortas because they were just brittle from the radiation. Fortunately, over the last 10 to 15 to 20 years, we don't see that kind of complications anymore because they do very precise amount of radiation now to the precise area which needs to be treated, and they have actually developed techniques where they actually have you like hold breath and do that 20-second breath holding thing. Anybody who's gone through radiation probably know this if they had it to their chest, that they have them hold breath so the heart is out of the field. They make sure precisely through lasers that gets out of the field, and then they zap that area, and then they let you take a deep breath. And that's the reason for the long breath hold when they ask you to do that. There's a good reason for it. And when the radiation therapy actually has heart in its field, the side effects are, one, blockages because of calcification of arteries. So you can have heart attacks if the radiation dose was too much and if your arteries were in the region of radiation. Two is valvular heart disease, where if this is the normal looking echo, this is the aortic valve, this is the mitral valve, look at these valves. This is a classic radiation-induced calcification of the valves. And it's hard to treat because it usually involves multiple valves, and these patients make poor surgical candidates because when you open up their chest, they do not heal well because of their previous radiation. Okay, so remember that cancer and heart disease have a lot more in common than we think. It's not just treatment related, it is the risk factors that lead to both of these. It's during the treatment, the stress involved with it, the poor functional capacity that follows that, and sometimes cancer therapy related side effects that come on many years later. But more and more cancer survivors, we want to beat the cancer, but more cancer diagnoses are happening, more people are getting treated, therefore we have more survivors, and we will be seeing a lot more heart disease in the future related to this. So physical activity can actually change your outlook, and the way it works is many ways. I'm going to let Stephanie talk after me about this, and I do want to point out that we have started a program called the CORE program, which is Cardio-Oncology Rehab and Education Program for patients who've had cancer and heart disease. And it's nothing magical. It's basically basic physical therapy, and to get out there, like somebody who's had a heart attack or a stent or cardiac surgery will go through cardiac rehab, which is a little bit more intensive. It's a stage 2, phase 2. They start a little bit lower, or they kind of stage you based on how well you're able to do, and they actually help a lot of people. The first thing is your mood gets better, second thing is you get into the habit of doing this, and I'm going to let Stephanie talk about that more. Please don't ignore high blood pressure and high cholesterol management because you might think, I have cancer now, these are the menial things. No, unfortunately, they still have a long-lasting effect on your, long life that's ahead of you. So don't ignore them. And talk with your doctor about whether you need an echo. Not everybody needs an echo, but if you go to your cancer doctor and say, hey, did I ever receive something that has cardiac side effect, and you've never had an echo after you finished your chemotherapy, that would be a good time to say, hey, you probably need an echo. Yes, even if it's 10 years after your chemotherapy, you are exposed to something that could have caused cardiac side effects. Yes, you need an echo. All right? And hey, why not? Yes. We'll take questions right after. She's, go ahead.
High calcium heart score, asymptomatic. Tell me, is there anything you can say about the heart and calcium? You kind of touched on it in that.
So, radiation does cause significant increase in calcium.
No radiation.
Okay.
Never any radiation.
Okay. Cardiac calcium score in general says that your propensity to have a heart attack or stroke over the next 10 years is higher than someone who does not have it. That is what it means. It does not tell you whether you have a blocked artery or not. If you're having chest pains or shortness of breath with activity, there's a chance that they are related. But otherwise, it basically is telling you in general that you have plaque buildup in your arteries. Okay? All right. Let me.
I'm Stephanie, and I'm a doctor of physical therapy at North Kansas City Hospital. I work primarily with our speak up. Yeah. Better? A little bit? Okay. I'm a little high pitched, so sometimes I'm hard to hear in general. So, sorry. So I work for North Kansas City Hospital. I work primarily with our cancer patients in our outpatient cancer rehab and in our cardiac oncology program that we have in collaboration with Dr. Malay. So I'm just going to add on a little bit to the exercise piece that Dr. Malay has already started with her wonderful presentation. So first and foremost, Exercise is helpful for patients that have cancer and for patients that have heart disease. So in general, along with like the regular exercise makes you stronger, we also know time and time again, research shows that exercise can help your cardiac muscles too. So it can improve your cardiac output, it can improve your stroke volume, and it also has benefits for your pulmonary function as well. So it can increase your lung capacity, which can help decrease how much carbon dioxide your body is holding on to. Both of these things together can also increase how much oxygen is getting to all of your tissues, which is just so good for tissue healing and good for our bodies in general. One of the important things on this slide is how exercise can affect your heart rate, and that is through the conditioning of that cardiac muscle. So if your resting heart rate is already high from cardiotoxicities or just general deconditioning, and then you go to do an everyday task like walk around the grocery store or walk into church, your heart rate has to increase to fuel your body to get through that task. If your heart rate's already high, those little tasks are going to bump it up and could be causing undue cardiac stress. Part of exercise helps lower your resting heart rate. And then when you go to do those tasks, your nice conditioned heart does bump up a little bit, but we're not stressing your cardiac tissue with those tasks. Exercise is also safe for everybody, but it's especially safe for cancer patients and for cardiac oncology patients. So the American College of Sports Medicine has done twice now 2 really big meta-analyses. This is where they take a long time and a lot of people and they look at all of the research that has come out about the subject, and then they make recommendations based off of that research. So they decide this is good research, this is bad research, they take the good research and make recommendations for people. So just last year they came out with their second set of recommendations, the first time in 10 years, and they made specific recommendations for patients that have cancer. Their biggest finding, of course, was that exercise is safe for patients that have cancer. We spent a lot of time in cancer research way back in the day saying, no, just lay down if you have cancer, don't get up, don't do anything, it's not safe. That's not true anymore. We want these patients up and moving. Their big recommendation that is going to impact our cardiac folks is that they recommend 150 minutes of aerobic exercise for cancer survivors. They define cancer survivorship as time of diagnosis all the way until the end. 150 minutes is a lot of activity. That's like 30-minute sessions 5 days a week. I don't even know if I always get in that much physical activity. It's quite a bit. And aerobic exercise is endurance exercise or cardio exercise. So think like walking, biking, swimming, those kinds of activities that really get your heart rate up and get your lungs pumping. They also recommend flexibility, stretching for patients, especially if you've had a surgery. We really want to make sure that those tissues stay soft and your joints stay mobile. And then general strengthening of your big muscle groups 2 to 3 times a week. They've also found in their meta-analysis, in general for cancer patients, that physical activity can improve your mental state and your physical functioning level. Those kind of go hand in hand. Those of you especially who have cancer or have a loved one that has cancer, you can imagine going through this is already so difficult on the emotional side, and then as you lose physical function through that and need more help, that can also be very draining to a person. So being able to be strong and continue to be strong while you're going through cancer treatment does a lot for people's mental health. They also found that physical activity for cancer survivors specifically helps with cancer-related fatigue. We're not going to talk a whole lot about that because that would be like another whole lunch and learn, but it is something that physical activity impacts for these patients, along with cancer pain and then your risk of reoccurrence of cancer. Specifically, the risk of cancer reoccurrence with physical activity. Those are the cancers that Dr. Malay was talking about that are impacted by things like obesity and sedentary lifestyle. If you're exercising during cancer treatment and after cancer treatment, then you're helping impact those numbers that could increase your cancer reoccurrence risk. So I'm going to talk a little bit about our core assessment. So our core program, like Dr. Malay said, is our cardiac oncology rehabilitation exercise program, and it is just for cancer patients that have had a cardiotoxicity. So when you come to see us on your first day, we want to know all about your history. So I want to know about how you were moving before your diagnosis, how you've been moving since your diagnosis, how much you like to exercise, all of those fun things. And then I want to know about your past medical history, especially past medical history that's going to be important for exercise. So do you have diabetes? Do you have an orthopedic issue? Have you had fractures in the past or surgeries? I want to know all about that. And then of course I want to know all about your cancer history. We've learned a lot today about how different drugs and how different radiation treatments can impact your cardiovascular system. And I really want to know what drugs you've been on and whether or not you had radiation and whether or not you had a surgery so that I can make that a part of my treatment program for you. If I never know what kind of cancer treatment you've been on, then I might not be able to treat you appropriately or monitor for signs and symptoms that something is changing. We're a big part of your cancer surveillance team. We work closely with our cardiac oncology team and with our regular oncology team. So if something is changing since you see us frequently or something new pops up, we want to know about it because we can help you find the right person to tell, or we can maybe encourage you that, you need to call Dr. Malay because your heart rate's been up every single time you come and see me, and she needs to know about it. And then we're going to go into more of your physical assessment. So I want to see how well your joints move and how strong you are. Again, especially if you've had a surgery, I want to make sure that that part of your body is moving well. And I'd like to know your balance and your sensation. For the balance and sensation, that is really more important for our patients that have been on a medication that's caused peripheral neuropathy. And well, balance is important, of course, for all of our cancer patients. We don't need you falling down while you're going through treatment. We don't need you falling down ever. And we do have parts of our program that focus on balance and focus on living with peripheral neuropathy. I don't feel like I've seen that quite as often with our cardiac oncology patients also having something that causes peripheral neuropathy, but we're definitely on the lookout for it. I also want to know all about your pain and your cancer-related pain especially, but that's something else, if you've never had pain and then one day you come in and you have a new pain and it's sharp and it's keeping you up at night, that means something has changed and we need to let your oncology team know about it. And then the last thing, of course, is all about your fatigue. So, like I said, we have a whole other thing on cancer-related fatigue. Fatigue does tend to affect about 90% of cancer survivors at some point in time during their survivorship journey. And cancer-related fatigue is so very different than any fatigue that anyone ever will experience. So it's very important for us to know about that because that's something we can help you with. And it's something that we can educate you about, which is really a big part of it because patients don't know that exercise is going to help them with their fatigue. They think it's something that they can just rest away when it's really not. And if you have a cardiotoxicity, that's going to make your cancer fatigue so much worse because your heart is working so hard to keep you up and moving on top of this other fatigue you have that you're just going to be wiped out. So I want to know all about that. We're also going to take your vital signs. That's the biggest part of your program. Our program, of course, is so centered around your heart. We're going to take your heart rate at rest. We're going to take it while you're exercising. We're going to take it after you're exercising. Same thing with your blood pressure. And then we're going to monitor your oxygen saturations as well. Especially if you're a patient that also has lung disease going on, we're going to pay close attention to that as well. The reason that checking your heart rate so frequently is important for us is because our exercise is dosed based on your heart rate. So like I was talking about earlier with your resting heart rate, how we're trying to get it to go down, we're going to monitor to see how much your heart rate is increasing while you're exercising, and we're going to try to keep it within certain parameters while you're exercising, and that's how we condition your heart rate. Just like the first time you go to the gym, you don't just pick up a 50-pound dumbbell, that would be too much. We don't want to stress your heart at that huge 50-pound dumbbell weight. We want to start it nice and light and then condition it until it can pick up that 50-pound dumbbell. One of the biggest ways that we monitor your heart rate through functional activity is through an aerobic test. We usually do the 6-minute walk test. Some patients need a shorter walk test or some patients need a more intense test. But this gives us a very good idea because it's a longer test of how your heart rate continues to respond while it's exercising. And then for safety, one of the biggest reasons to come and see us versus just starting an exercise program on our own, not that I'm ever going to discourage somebody from exercising, go for it. or seeing a personal trainer is because we really have the tools and we have the education to help you progress this along safely, especially if you're somebody that has a cardiac toxicity, because we have the tools and the knowledge to monitor your vital signs while you're with us and really watch how your heart rate's doing. And of course, PTs are all about balance. You're not going to fall with us. It's like the big typical PT thing, right? Gait belts in the hospital, gait belts in outpatient. We're going to keep you standing. And then how much you're breathing and how much you feel like, whether you feel like you're working too hard is something we're going to monitor. More on safety here, like I said, we are trained to recognize signs and symptoms. We are trained to look at red flags as you're going through treatment. We're trained to look at making risk assessment for things like blood clots while you're with us. Not that we're not going to bust out the sauna, but if you have something that seems concerning, we're going to be talking closely with your cardiac oncologist or with your regular oncology team. We are part of your cancer surveillance team, especially if you're somebody who's maybe further out from treatment and you only see your oncologist every 6 months. You're going to be seeing us pretty frequently, and we want you to tell us if something's going on, and we can relay that into your cancer team or encourage you to find the right person to get help. Okay, so these are some exercise principles in general here. So the first principle is individuality. So as much as we have targets for your heart rate and certain things we like to do and metrics we like to hit, our programs are going to be individualized for you. You all have different cancers, you all have a different past medical history, you've all been on different treatments, and your program is going to be tailored to you, especially because we want your exercise to be fun. So if you really hate walking and I give you a walking program, you're not going to do it. So we want to find something that you enjoy doing, an exercise that you like and is fun for you, and we're going to tailor it that way. The next principle is the principle of overload. So another good reason to come see specifically a core PT or an oncology PT versus somebody else is sometimes practitioners get a little nervous working with cancer patients or working with elderly patients, and you might be an elderly cancer patient, and they don't want to stress you enough. They're going to go too lightly on you because you're frail and you've had cancer. But we know the research, we know what's best for stress on your systems, and we know when we need to tell you to back down or when we need to tell you to ramp up a little bit. Especially our cardiotoxic patients, we have a lot of young breast cancer survivors who feel great when they exercise and they go hard, but their heart really can't take it. So sometimes we have to tell patients that they need to back off a little bit. That's too much for your heart, even though you feel great when you're exercising, you need to back it down and be safe for your heart. The last two on here are progression and reversibility. So progression is us guiding you through your treatment. We're going to talk in just a minute about how we progress in your different stages of cancer, or your stages of cancer treatment, but we are there to safely guide you and your heart through treatment. And then the last thing, regression. The saying that if you don't use it, you lose it is so true. I know the best that I can. I understand that it is difficult to want to get up and exercise, especially when you don't feel good. But if you don't stress those systems and if you don't get up and move, it is going to be so much harder on the other side to build your strength back up and to help start repairing your heart. Okay, so quickly, these are our phases. So phase 1 is while you are in active cancer treatment. Our goal during this stage, if you're coming to see us, is to keep and maintain your functional level the best that we can, and to keep you strong enough that you can continue to tolerate treatment. Studies are still coming out about how much exercise during treatments helps chemotherapy work better or not work better, or radiation work better, not work better, but we do know that patients that are in better physical condition as they go through their treatments can tolerate their treatments for longer and can sometimes tolerate a higher dose of the treatment versus their peers that were already fragile before they went in. And we want to keep you out of the hospital, we want to keep you at home, and keep you doing your treatments as long as your oncology team wants you doing those treatments. This phase is while you are in active treatment for about 3 months after. The HRR on the screen is your heart rate reserve. This is how we monitor how much stress is being put on your heart. So we do some calculations about what your max heart rate should be, and then we take a percentage of that, and we keep your exercise within those limits at all time. During this phase, it's rather low, so it's a low intensity, and it's only a 30 to 40% of your target heart rate. This is a lot of times where we gotta make people back down just a little bit, because sometimes even just a short 2-minute walk can bust you out of this 40%. So we gotta rein people in just a little bit on this one. This protects your heart while you're going through treatment. So phase 2 is once you're done with treatment, plus about 3 months. Now we can start bumping up your activity just a little bit. Some of those nasty drugs are starting to really get out of your system, and we can increase your intensity. Your goal in this phase is to start bringing up your baseline. So we're starting to get you back to that normal feeling. And then the third phase, at this point, hopefully you're all done with us. You're like 6 months out of treatment. Hopefully you came to see us during phase 1 or phase 2, and you're ready to exercise on your own. By this point, we've educated you about how to monitor your heart rate and what percentage your heart rate should be at and all of those fun things, and you're ready to just continue exercising at home or in the gym or wherever you'd like to exercise. Okay, and then the last, our last phase on here is the forever phase. So we want you to be a lifelong exerciser. Cancer is now a chronic condition. That diagnosis is going to follow you for the rest of your life, unfortunately, and especially if you have something cardiac on top of it. So we want you to continue exercising, continue to keep your heart rate at a good level for really the rest of your life. And then if you do unfortunately go back into remission, then we would bump you back down into phase 1 while you go through treatment again. We need to bring your heart rate back down to protect it as you go through this next round of treatment, and then progress you back through the phases. So, how to get hooked up with a PT? We do need a physician referral in this state. I would recommend talking with your cardiac oncologist or your cardiac team, your primary care team, your oncologist, whatever physician you see. Any of them can get you a referral to us. And it is covered by your insurance, typically covered by your insurance. If you have an insurance that has a therapy benefit, then we are covered because we do bill just like typical physical therapy. So, questions?
So we continue it down, I can still come?
You can totally still come. We'll take you. You probably won't need us that it's long. It'll probably be like 1 or 2 visits where we help you get on track, but we'll take you.
Great.
Everybody else?
I have a question, Dr. Malay. What painkillers are more safe for your heart? Because I hear a lot of things about ibuprofen.
Good question. It's different in different people, okay? If you say have kidney problems, and you have like diabetic nephropathy or something, too much of E, too much alcohol, too much of any of that is also toxic to your kidneys. And there's a small increased risk of heart attacks in patients who take NSAIDs, the group that you just mentioned, the ibuprofen, the Aleve medications, on a daily basis. And it's a cumulative effect. It is something you can actually accrue over a period of time. So we typically tell patients, hey, alternate Tylenol and Advil. Talk to your pain management doctor about what other options you could have. You know, if it's a neuropathic pain, something like Neurontin or Lyrica, which does not have cardiac side effects or kidney side effects, is probably a better option for you because it lasts longer or is a, will work better for your kind of pain. But there's no specific, oh, this is a great safe medication for you because opioids are addiction forming, they have their own side effects, and minimum amount of medication at the least frequent interval and not to be in pain, living in pain is not recommended for sure.
Right, I'm like talking about like say weather changes, arthritic, how you have joint pain and
unless you have liver
headaches,
issues, Tylenol is a good start. Okay, the extra strength Tylenol, which is a 500 milligrams, usually carries through at least 6 to 8 hours. Good. Yeah, but make sure the generalized recommendations are hard to make because people who have liver issues, if their liver enzymes are high, Tylenol is not good for them. That's why I don't want to make it a general recommendation. Okay. Yeah. The good principle is to actually alternate. Don't take the same medication for 6 weeks in a row at the highest possible dose. There are side effects. Every medicine has side effects.
Oh yeah, and one of them that I had in question was meloxicam.
Yes, that group of medication, like we had like Celebrex and Vioxx and all those were the ones that had the red flag about the increased risk of heart attacks when taken continuously.
Meloxicam is an NSAID too, and it does have the kidney side effects I'm talking about. Piroxicam, meloxicam, good medications, they really help. But you know, again, use it as recommended by a doctor. Don't take it for like, okay, I take 1 pill a day, I've been taking it for the last 2 years every day, is not the right way to do it. Okay? Yeah. Anything else? All right. Thank you for coming, folks.
I'm gonna take the rest of it. Okay. If that's okay. Yeah. I was interested in